physical therapy approaches for individuals living with Huntington's disease. So my name is Robyn Wilson. I'm a physical therapist through the Duke University Health System, and I've been with Duke for 18 years. I specialize in treating adults with neurological conditions. And so just a couple of discussion points that we'll just review today. So we'll talk about, very briefly, talk about Huntington's signs and symptoms. You all are very familiar with these, so I'm going to go through those really quickly. And then we're going to discuss the role of physical therapy, which includes our recommendations, our evaluation process, and the support that we've seen in research recently from some of our PT clinical research colleagues. We are one of only 29 in the entire country and the only one in North Carolina. This is not an exhaustive list of our team, so we have several interprofessionals that work with us. This is not an exhaustive list of symptoms, nor does this indicate that every person will get every symptom. This is just symptoms that can be related to movement, it can be related to cognition or thinking difficulties. You can have symptoms related to psychiatric disorders. Many of these symptoms can occur in all at the same time. They can occur in different stages, or you might not have them at all. The voluntary impairments is oftentimes the greatest impact to the individual's independence. And we had a great talk from Lisa last session that talked about chorea. And chorea, even though it might seem like that would impact an individual the most because it is the most visual, it is oftentimes not the highest impact for the individual living with HD. And us as physical therapists, we actually work on treating the voluntary movement impairments, not the involuntary movement impairments. And so that kind of brings me to the next slide. I'm getting a little ahead of myself. So how can physical therapy help? So we work at reducing symptoms and trying to maximize potential, maximize functional potential. So we really work on more of those voluntary movement disorders that somebody might have. We provide recommendations for exercise guidelines, and we help you find exercise that is most beneficial and most safe for you. We tailor a very specific program for each individual. Not just one size fits all for anybody really, but definitely not one size fits all to someone living with HD. We talk a lot about safety. We talk about safety in the home, safety when you're in the community. We talk about different types of devices that can ensure and optimize your safety. And like I said, we assist with those voluntary movement impairments. And so our goals our goals for PT intervention are very much dependent on the stage. So there is an inverse relationship between the stage of HD and the impact of physical therapy. The earlier the stage, the more the impact. So as we get later into the stages, physical therapists might not have as much impact on the individual. We will focus a lot more on the care partner at that time and trying to really support the care partner and help keep the individual safe and try to help educate the care partner as well. And obviously prevent secondary complications from occurring. So this is a very busy slide, but basically we do some different things in each stage. A lot of overlap, but different emphasis. So in the earlier stages, we're going to really be talking about health promotion. Lots and lots of education here about the importance of exercise, the type of exercise, how difficult the exercise should feel. And we want to make sure that we're still keeping safety as number one. So exercise cannot compromise safety. So we have to find that very special tailored intervention just for you based on your abilities. We educate on the importance of early intervention, how we can really play a big role in trying to maximize your potential and slow the progression of the disease through exercise. We talk about any kind of barriers that you might have. That might be home barriers. That might be barriers to just do not like to exercise. I've never liked to exercise, so we talk about that. Not everyone likes to exercise. I recognize that. I'm from a family of non-exercisers, and I'm just this one person that enjoys it. So we recognize that it is not a one-size-fits-all. We grade exercise. We don't just say you got to go out and go full force tomorrow. We talk about how to make it so that it's very reasonable for you. And then we do work on the referral process. So the outpatient physical therapy referral early in the stages, we sometimes might suggest that you consult with a therapist that's close to your home. So in the clinic setting where I'm going to be working and seeing some people that are coming from all over the country or all over the state and all over the counties of North Carolina, we're going to try to find a local clinic that can help work on tailoring an intervention over a course of 12 weeks. My goal usually in clinic is that I'm going to try to find somebody that is a neurological physical therapist, and not all physical therapists treat neurological conditions. So we want to really try to find clinics that have a specialized therapist for you. In the mid stages is when we're really focusing in on safety. We're really going to be focusing on falls prevention and probably thinking about durable medical equipment, which is DME. That's just walkers, wheelchairs, different types of devices. We'll try some of them out in clinic if we can, because oftentimes not every device is going to be safe for everybody. So we'll try different things and decide which one is going to be the most helpful for you. We're still working on education. We're still talking about the benefits of exercise. We're still going to be pushing that high intensity or that moderate intensity exercise, which we're going to talk a little bit more about. And then this is really where we're mostly referring people to PT in these middle stages. So outpatient PT clinics, local neuro PTs, or we might even recommend home health PT if you have if difficulty navigating in the home is starting, or if navigating in the home is starting to get difficult, or if you have some transportation challenges, that home health PT would be a better fit for you. And then in the late stages, we're really focusing more on the caregiver training and helping your care partners. We are still looking at some medical equipment devices, whether that be a transport wheelchair or more of a specialized wheelchair. We have a seating clinic in Durham, and there are seating clinics all over the state that do very comprehensive, detailed assessments for custom wheelchairs. And so if an individual is having a lot of difficulty walking and it's expending a lot of energy and falling all the time, we might talk about going to that seating clinic to get a specialized wheelchair. If it's just something that they would like to have a wheelchair in the community when they're walking long distances, and it's just for those purposes, we might think more about a transport wheelchair. So we talk about that. And talk about home modifications and improving your safety in the home. We'll talk about lighting in the hallways. Where's your bathroom? We work with our colleagues in OT to talk about how to make your bathroom as safe as possible with devices. Clearing clutter, removing throw rugs, things that will help somebody navigate more safely and optimally through the home. And the seating clinic and with caregiver training, we might also focus on pressure relief and skin integrity as well. Our PT evaluation is very similar to any other evaluation. So we'll gather a subjective history. That's just basically talking to you about things that are challenging for you, things are going well, what kind of support you have at home, what is your house set up, to identify any kind of barriers that you might have, who's with you at home, and then figure out how we can best help you. We have very specific standardized assessments that we do that have been studied and have values that are very specific to Huntington's disease. So we will go through many of those with you. And then we'll get into the real meat of the assessment, which is the exercise prescription and the recommendations, which is what we'll focus on in the next slide. And then following up and creating a plan for you. And so when we think about exercise prescription, we look at the research that's been done very specific to Huntington's disease. So there's some PT researchers that got together in 2020, I think right during the pandemic, and they were therapists named Lori Quinn, Ian Clues, Deb Keeblemeyer, and a whole bunch of colleagues. And they looked at different optimal interventions as it pertained to exercise for people living with HD. And they took a whole bunch of different interventions and they studied them, and they decided which ones were going to be the best forms of exercise. And they used this grading system to grade evidence. It's either very, very good evidence, which was grade A evidence, and that's usually through clinical trials. Grade B evidence is more like opinions or lower end research, and then C is like more consensus. That's opinions and consensus. So they found that grade A evidence was supporting aerobic exercise and some strength training exercise at a moderate to high intensity. Gait training or walking training also can improve your spatial temporal relationship, which is kind of just like where your body is in space. And then in the later stages, there's positioning devices and then seating adaptations and the care partner training. And so what is aerobic exercise? What does that even mean? So aerobic exercise can be anything that will get your heart rate up. And so it can be walking over either uneven or even surfaces, depending on your ability levels. It can be cycling with a recumbent stationary bike. You can also add resistance to that to get that strength training component. You can do gardening if that's something that you enjoy. You can do dancing if that's something that you enjoy and that is safe for you. So basically, it's anything that's going to get your heart rate up. When you're exercising at a moderate intensity, you're going to be breaking a sweat, and it's going to feel hard to you. We have specific scales that we use to determine what type of intensity that you're exercising at. So there's the very basic scale, which is at the bottom left called the talk test, and that's a good easy scale that you can use. So if you're exercising at a moderate intensity, you can talk, but you can't sing a song while you're exercising. If you're at a vigorous intensity, you might be able to say a couple of words, but not without putting a breath in between. We also use heart rate. So there are heart rate calculators that can help determine what percentage of your heart rate max you're exercising at. Basically, if you are exercising at 70 to 85% of your maximal heart rate, you are at a moderate to vigorous exercise. And so sometimes we'll use that. We can run a heart rate monitor, and we can use a calculator to determine exactly what percentage you are exercising at. That percentage is based on your age and whether you're taking any kind of beta blocker medicine. And then there's these perceived rate of exertion scales. So you might have seen these before. There's two different scales that you might see similar, a 6 to 20 scale, or this is the 1 to 10 scale. This is the one I like to use because it seems more, 1 to 10 is just a scale that we're more familiar with. So when you're exercising at a moderate to high intensity, you should be in this yellow phase. That means that it's hard, it's challenging when you're thinking of how much effort you're putting into the exercise. We like to exercise in the green. I like to exercise in the green. Most people like to exercise in the green. Kind of easy, kind of moderate, kind of that conversation pace is what you like to call it. The maximal benefits that we see in research and anecdotally as well in clinic is going to be that yellow zone if you can get into it. So in physical therapy, we try to help put you in that zone because oftentimes people don't really know how that feels to be in that zone. So we put you there in a safe way, then try to help guide you into grading your exercise at home to get you doing that safely at home as well. Okay. All right. Now we're on the recommendations and plan. So we talked a lot about this already. So we're going to recommend things like assistive devices based on what you need, what's the safest. If falls are a big issue, we might talk about using something like a rolly or walker to help you navigate a little bit more safely. We might talk about transport wheelchairs, and we might talk about custom wheelchairs. Home safety and falls prevention. So we will talk about different things that will help prevent falls in your home. Optimize your safety, lighting, clearing clutter, getting specific devices maybe in the bathroom, and then getting referrals for physical therapy for home or outpatient, and then finally caregiver support. So that is like our entire plan that we'll usually help you come up with in the clinic. And so now it's the last bullet point, which is that community-based exercise program. So several years ago, up in Vermont, a team of therapists came up with an exercise program that was actually developed for people living with Parkinson's disease. They called it Pushback PD. And it was originally in person, and then it actually moved to a virtual class kind of around when the pandemic started. And from that class, they decided that we can do more than just Parkinson's for this. We can develop this for Huntington's disease. So they developed this class called Pushback HD for Huntington's disease. And so it does focus on the various movement impairments associated with HD. It's a virtual exercise class that is not considered physical therapy. Physical therapists do lead this class, but it is not physical therapy. So the good thing is it can be done simultaneously with physical therapy. And we do focus on all the different little boxes that are seen here in the slides. So we work on strength training, we work on flexibility, we work on postural alignment, balance, and then we add a cognitive challenge during the class. And so, it does specifically target the movement impairments associated with HD. So it targets some force modulation problems somebody might have, bradykinesia, or that slowness of movement, that motor impersistence, so that difficulty kind of sustaining smooth muscle contractions, dyskinesias, poor balance. So it does focus on that. It's a combination of a sitting and standing exercise class with a cognitive challenge that's done in sitting. It does have aerobic intensity kind of built into it, but it is really the individual's option of how much they want to take it. You can do, lots of different people of lots of different ability levels can do this class. So it is designed to be graded and modified so that multiple people can participate. Yes. Force modulation problems is like difficulty, and with power, difficulty getting power, generating power. That's what I was looking for. Yep. And also difficulty with changing between power and not power. So like modulating in between different kinds of different kinds of muscle contractions. So the class outline is just, we start off with a warm up to music. Then we move into a circuit training. It is 5 35-second intervals that we'll do, both in sitting and standing. Then we'll do the Clock Yourself, which is our dual task cognitive challenge. So it's an app called Clock Yourself that we do in sitting, and it forces people to have to do some thinking and moving at the same time. And we make it do a speed. So it's like you have to think and you have to move quickly. And then finally we do a cool down at the end. This is about a 45 to 55-minute class. And so at the beginning of class, we'll start with the warm up. At the end of class, after our cool down, we'll probably all get together. We do like a little group dynamic, group building part together where we all talk about how our week was going, some good things that happened, just something about you that maybe everybody in the class doesn't know. And, you know, just helps build some team dynamic, just helps build some community within the class. And so a lot of people want to probably know, well, how do I participate in this class? So basically we get referrals from lots of different people. So oftentimes I'll get referrals from physicians. I have myself gotten referrals. I have referred people from HD Clinic to the class. We also sometimes will get referrals from other colleague physical therapists from other states that work with people living with HD. And once we have a referral, or once we find somebody that's interested in taking the class, we do set up a 45-minute one-on-one via Zoom meeting with that person. And it's really to try to make sure that it's a good fit for both parties. So we want the care partner to be present during the meeting. We go over kind of the logistics of the class. We talk about kind of the foundations of why we do the class, the fact that it's not physical therapy, that it's community-based. We also go through all the different exercises with the individual to make sure that they feel comfortable with them, they're safe doing them. They do not have to do them perfectly. Nobody does the exercises perfectly. Everybody's at their own level, but we do want to make sure that they're safe and comfortable. Other logistics we'll talk about is technology, to make sure you have good Wi-Fi, to make sure you have a good place in your home where you can set up a computer and sit and I can see you. I want to be able to see you. If you're sitting, I want to still see part of your legs, just so I can make sure that I can still see you doing the exercises, make sure you're safe, and then support from my care partner if needed for the different transitions that we do throughout the class. This is just a little flyer that we made up. Now, the class is currently being held Mondays and Friday afternoons. This is very much subject to change. Unfortunately, the other therapist, she was actually one of the creators, Farm Pageant. She's from up in Vermont. She has moved on to another job, and she is now just teaching the class temporarily, kind of on her own time, because she just loves this community so much. But they are like actively looking for a replacement for her. So I will continue to teach the class, but our times might shift a little bit based on the schedule of the new therapist teaching the class. But it will be twice a week for 45 to 55 minutes. All right, so I know we got other speakers here. So just the quick take-home points. So PT and exercise is very much supported in research for Huntington's disease, which is fantastic for our profession that we have seen such great things in research. Exercise can help preserve function, delay some symptom progression, but early intervention is very important. So don't wait until the symptoms become such that they are it's really impairing your quality of life. The interventions will greatly depend on the stage, and then the community-based exercise program are available and can help with fitness levels and sense of community for Huntington's disease.
I always like to start off to see if people know what occupational therapy is. So raise your hand if you know. Have you heard of it? Okay. Okay. All right. I know I have, okay, this is a great representation. I feel like this room knows not a lot of people do, but I like to ask because not everybody does. But we're the ones, like I said, that are working with you to make sure that you are finding those meaningful activities that you want to engage in and making sure that those things are going as safely and independently as possible. And so we do that in a lot of different ways. And I'm going to talk through that as we go on through this presentation about intervention strategies that can help you continue to live that meaningful life that you want to live. All right, so some strategies for maximizing your independence during your daily activities when you are dealing with symptoms of Huntington's would be to establish a routine. So if you know what you're doing in your day and have a pretty good routine, then there's not going to be a lot of confusion on what's coming next. There's the expectation of what's coming already there. And it can be really helpful for continuing to engage in things, especially if there's changes in mood or apathy and wanting to engage in meaningful things. So establishing that routine, and then if needed, using something like a written or a visual schedule to help stay on task. That's something that an OT can help. Sometimes in the clinic, I'll help work on making those things, working with care partners to make those and establish those routines. And then prioritizing activities during the best hours of your day. So I'm not a morning person or an evening person. So middle of the day is probably my best. And actually not really after lunch. So maybe late morning, I don't know. So prioritizing your activities when it's going to be your best time, especially for those more challenging activities. Doing things that you don't necessarily or find to be more challenging. If you can, you want to try to do that during those best times of day. So that might mean, if you can, making appointments for doctor's appointments or therapy appointments during those best times of days. And then promoting safe practices. So that might be to reduce risks of falls, might be to sit down to do things that maybe you didn't used to do, but now sitting is going to be something that's a little safer, so it's modified, but you still get to engage in that, just doing it in a different way. Using adaptive equipment, which I'll talk about in a minute, might be an option, and then modifying activities. Like I said, kind of sitting down, doing things, either kind of breaking up tasks, maybe when you didn't used to have to break up tasks, but again, modifying the way that you do things so you can continue to engage in them. So I am going to leave all of the dressing techniques to Anita, who is an OT student who's going to be talking after me. But I'm going to talk about some of the other adaptations or devices that might be helpful. And this is not even nearly exhaustive. There are so many things out there, but the role of an occupational therapist is to check in with you and see what is maybe becoming more challenging and how can we help give you some strategies to make that easier, if that's through using equipment or modifying your home. And we've talked, a few people have talked about having an occupational therapist come into your home, which generally, if you have home health services, you need to be considered homebound for them to get those services, but to have them come in most situations. But if you're confused about that or have questions, certainly talk with your team, talk with your provider to see how you can get those services in your home, because it can be really helpful to have somebody see what you have. Or I have clients bringing pictures all the time. Can you look at this? And I do my best, but yeah, I can take a look and see, like, oh, we can move that or add this here. But making sure that your bathroom is set up safely for using the bathroom, getting into the shower, things that you can do for getting in and out of bed mobility, adding rails, that sort of thing. Various devices for feeding or eating. Things like having a built-up spoon, having a heavier weighted spoon can sometimes help. Using a cup to put a utensil in, just so if the movements are causing difficulty holding on to things or dropping things, sometimes having a cup to put in your utensil can be helpful. And then there's a variety of different plates that you can use that have lips that don't move around on the table to make it a little bit easier. adaptive scissors, it just is harder to hold on to the scissors. Cups that have a lid and handles. There's a variety of options out there these days, but just some examples. Again, not an exhaustive list, but hopefully you have access to an OT that can help you kind of problem solve some of these things. Another thing that an occupational therapist might do when they're working with you would be to talk about activity modification. So there's a variety of different things that you can do. Sometimes changing the organization of your home can be helpful. So if you're having to go from the kitchen to the living room to the bedroom and all over, and mobility is more challenging, just the way that you organize things so that you're going to have everything that you need more in one place versus having to go all around can be helpful. Again, we talked about that routine, establishing that routine. Avoiding time pressure. So if you were in the other talk, we were talking about how it takes more time to do things. Everything that you do can sometimes take more time. So the strategy would be giving yourself a little bit more time so that you're not having to try to speed up, feel the pressure of having to go quickly, which can sometimes even cause symptoms to increase because of that kind of stress. So trying to avoid that by planning ahead, using that adaptive equipment and the compensatory strategies. So we do know that sometimes there can be changes in cognitive function with this diagnosis, and so the strategies for this are also going to be compensatory strategies. So things like using external aids. What that means is external to you, something that can help you with memory, with attention. So using calendars or alarms, to-do lists, reducing distractions, such as like TV in the background or something that can be more distracting, and then using those routines that I talked about. Another thing I wanted to talk about was the use of mindfulness, which is kind of a buzzword these days, but it is something that there's a lot of research on and research on in the HD community that can be helpful for people to manage their symptoms. So the purpose of mindfulness is to learn strategies to make a connection for mind and body, because we know that Huntington's affects your nervous system, and if you have stress or anxiety, that is impacting your nervous system, and so it can impact your symptoms, either causing your chorea to be more prominent, causing increased difficulties with stress or anxiety. And so there's ways and strategies to help calm that nervous system down and help calm the symptoms down. So I wanted to go through a quick mindful moment, if everybody's up for it. Feel free to participate if you'd like. So what I'd like you to do is just be as comfortable as you can in your chairs. And I want you to take a slow, deep breath in. And then think the word relax as you slowly breathe out. Feel the relaxation flowing down through your head, down through your face, down through your shoulders and your trunk and your neck, down through your legs and feet. And think the word relax as you slowly return to what you were doing. Notice how your mind can stay alert, your body relaxes. How's that? Good? Good. Yes, it is. So you can kind of see how learning some strategies like that can be really helpful to implement, and that there are things that you can do to help calm that nervous system down and calm the symptoms, which I think can be pretty powerful. So I'm going to talk about everybody's favorite. I always do the mindfulness first and then talk about driving. It's a hot topic, but one that your occupational therapist is trained in addressing. So driving is something, of course, that is super important for our independence, but it is something that can be impacted with a diagnosis like Huntington's. And so part of my role in the clinic is to look at the skills necessary for driving to make sure it's safe. Because just because you have Huntington's doesn't mean you can't drive. In fact, we want you to drive as long as it's safe, but if it's not safe, of course, we don't want you to drive. And that's where we're kind of working with the team through that whole approach to help make the transition to potentially not driving as seamless as possible. So what we do is we talk with care partners, we talk with friends. They might be the first ones noticing the one symptom of Huntington's may be that anosognosia, which means you might not necessarily notice the changes in function, but the research says that care partners and loved ones are a reliable source of information in regards to their loved ones driving. So we take that information into account. It's not the only thing. But then we talk with the clinic team too. So it's not just me, but if I see some things I'm concerned about, I'm going to be talking with physicians as well. And then we do have clinical driving screens, potentially. There's not a ton in the state of North Carolina, but we happen to have 3 sites that do this. But and I'm a certified driver rehab specialist. So I also have the certification in it, and this is something that we do. But we do offer a comprehensive community mobility evaluation, which is clinical. It's not on the road. It's 2 hours looking at physical, cognitive, vision, and reaction time assessments. And then problem solving through what's next. We might recommend that you go for an on-the-road evaluation with driving certified industry. The cost for that is $200. I do. It's out of pocket, not covered by insurance, but and we do require for physicians. Okay, so real quick, just to end, because I want to leave room for Anita, but I think there's a lot of benefits to occupational therapy, but I'm obviously very biased. So I think finding your, if you have anything to give you, finding that occupational therapist on your care team, and they want to be on your team and help you continue to live the most meaningful and independent and safely as you can in those meaningful activities.
My name is Anita. I'm an occupational therapy student at Duke University. And so I'm just going to be talking about dressing and clothes with Huntington's disease. And to get started, let me street this a little bit. There we go. So when we get dressed in the morning, really a lot about it, but there's a lot of tasks that we have to do. So the first thing, we have to go into our closet, or we have to scan your closet. You have to select what you're going to wear. Then you're going to pick your clothes. You have to put them on. And then you are going to adjust your clothes, maybe in front of a mirror, whether that's putting on buttons, zippering. And then at the end of the day, you're going to take off your clothes. So with that, there are a lot of steps to dressing. A lot of us don't think about. And then, as we all know, there's definitely some challenges with HD, specifically with our zippers and buttons, even jewelry, which a lot of people don't think of. That goes along with our clothes that we like to wear. And then, so some adaptive strategies that we can think about when we are dressing are the positioning of when we're dressing. So a lot of the times we suggest to sit down to reduce the falls risk and loss of balance. Also the appropriate sequencing when you're putting on clothes. So when you're sitting down, you may want to put on your underwear, then your pants, and then you'll pull them both up at the same time instead of one up and then the other up. And then that can be a shirt you'll put on one sleeve, another sleeve, and then go over. So making it less exhaustive and stressful. And then the reduction of visual clutter. So our closets everybody has their closet differently, but having it less stressful, having things organized, maybe color coordinated, in a good visual field, and be less stressful overall. I have a few tips for adapting your own clothes. So first, there are adding Velcro to your clothes, so you can add it to the inside, inside here, and then you can have your button showing and just, but have the Velcro close it like that. You can also have magnets. I researched a hat grip made
I know
good.
some home,
It's
you know,
Korea, and a lot of movements. If you like to wear hats, you can put a hat grip, which is like a little foam, little patch, just to reduce the hat from flying all over the place. And then a zipper grip is good. You'll just connect it to the zipper, and you'll have a bigger grasp when you're zippering your sweater. And then elastic shoelaces, which I know a lot of people still love to wear their shoelaces, also can be a tripping hazard. If you don't want to use Velcro shoes or slip-ons, you can put elastic shoelaces so you can just lift up the lip and then slide your foot in. And then last thing, purchasing adaptive clothing. If you aren't aware of adaptive clothing, there are definitely some brands out there where you can purchase some clothing. It may be a little daunting to type in the word adaptive. And also, I was listening to a panel to NC State this past week, and the term adaptive can also make it more.
So if I was in Western Massachusetts, they would
Which
come in.
I realized too when I've been researching clothing.
That's not.
So I put
It's
some
not acceptable.
key search terms
Frankly.
for you to
And
just
by the
think
way, the
about,
regulations I
and
talked
those
about,
can act as
you get a chance
the
to circle back around.
word adaptive.
By
So
regulation,
things like a front fastener
people
for
with
a bra,
honey's knees, no matter whether they're 35 or
elastic,
65,
adjustable, relaxed fit, loose
by
fit,
regulation,
bra
all of their
straps,
needs should be able to be met
are
in a
some
nursing home
buzzwords that
program.
you can look up when searching
Which is why I
online.
talked about
And then
culture.
these are just
What you're
kind of a
fighting is
list
culture, not the
of
design of
brands/stores
nursing.
where you can search some clothes.